Okay, hello everyone. This is to the MRCP refresher course. My name is Dr. 𝒍𝒊𝒄𝒏 𝒊𝒉𝒂𝒍. I'm a consultant gastroenterologist and advanced endoscopist. I currently work at Nottingham University Hospitals, and it's a great honor to be presenting this course to you. So to start off, today's module course will be mainly on gastroenterology and hepatology. It will be useful to go through a few questions and explanations. So first question is a 23-year-old male presenting with difficulty in breathing for last 2 days to a pulmonologist. Past history reveals similar episodes over the last year. He's also suffered from pain in abdomen intermittently over the last month. He has diabetes mellitus and is on medications for this. On examination, he has pallor. So the investigation showed abnormal liver function tests over the last 2 months, and an abdominal ultrasound showed fatty liver and gallstones. So given the most likely diagnosis, what is the disease prevalence in Northern Europe? So here from this question, you're sort of being expected to give us a diagnosis, and from that diagnosis, you're supposed to know what the prevalence of this condition is in Northern Europe. So let's look at the answers. So we've got 1 in 3,000, 1 in 1,000, 1 in 1,500, 1 in 3,500, and 1 in 300. So it's important to know, first of all, what the condition is and then know what its prevalence is. There's really 2 questions in one. So the answer for this one is 1 in 3,000. So the diagnosis here for this gentleman is cystic fibrosis. So the diagnosis or the prevalence would be 1 in 3,000. So you can't really get this answer without knowing that the patient has a cystic fibrosis. This is an autosomal recessive disorder. It's quite relatively more common in the Western world, where diagnosis is much more readily available. So just going back to the question, it does affect so the pancreas, the GI tract, and the liver. And so that's why 1 is 3,000 is. Okay, moving on to the second question. So a 39-year-old gentleman presents to gastroenterology clinic with weight loss and vomiting for about 6 months. On physical examination, he's found to be anemic. Investigation shows raised anti-endomysium antibody levels, liver function tests, and a low level of albumin, calcium, and hemoglobin. Diurnal biopsies demonstrate villous atrophy, consistent with the diagnosis of celiac disease. So which cell type is responsible for the hypersensitivity response against gluten? So looking at this question, you could have just actually gone to the last line and you wouldn't have needed to read through the whole question. But it is difficult to know which ones to read, so it's best to spend time reading it properly on the first occasion. So looking at the answers, so this is T cell, B cell, natural killer cell, lymphocytes, or macrophage. Here the diagnosis is, so there's a 39-year-old chap. He's got weight loss and he's got sickness, anemia, endomysial antibody level. This is all pointing towards a diagnosis of celiac disease. He's got low albumin, calcium, and hemoglobin. Biopsies have confirmed that. So you just really need to know the answer to the question without needing to know anything. So the answer here is, of course, it's T cells. That T cell is what the hypersensitivity is with celiac. Celiac is relatively, again, common like the cystic fibrosis, more towards the Western world, but obviously it is being picked up more in the Eastern world these days to changes in. So the next question is a 68-year-old man is referred to the gastroenterology clinic with chronic abdominal pain and fatigue. An upper GI endoscopy showed a probable heel duodenal ulcer. Helicobacter pylori screening was negative. Examination reveals a BP of 122, pulse is 82, and regular BMI is BMI is 24. The abdomen is soft and non-tender. PR reveals an empty rectum with no masses. So investigations, fecal or cord blood is positive, which is the most, following is the most appropriate step. So looking at the blood results, you can see he's got anemia, he's got microcytosis, and those are the main. So what's the next investigation you would do? I think in this chap, the answer is colonoscopy, and the reason for that is going back. It's a 60-year-old chap. He's had his upper GI endoscopy. We've got anemia, and there is also this fecal occult blood is positive. So the blood results, sorry, the stool result from him is, which is called FOB in UK, is positive. So that would point more towards a lower GI pathology. So the next most appropriate next step would, of course, to examine his lower GI tract. So looking at the results, the capsule endoscopy is more towards examining the small bowel. Colonoscopy, of course, is the correct answer. Sigmoidoscopy would only visualize the left side of the bowel, and you wouldn't be able to visualize the rest of the bowel, and is inadequate and inappropriate. Barium enema is not really used these days, and CT abdomen, especially when it's plain, will not pick up any polyps or early malignancies, especially flat lesions. CT colonogram is something that could be considered, but the gold standard is colonoscopy. So next question is, we move on to a 33-year-old Hispanic female presented with fatigue and abdominal pain in outpatients. She's diabetic. Her current medications are metformin and glycoside. Past history reveals she's got PCOT, which is polycystic ovarian disorder, and is under treatment for that. She drinks approximately 15 units of alcohol. On examination, she has a BMI of 37.4, which is clearly elevated, and has 7 centimeters of hepatomegaly. So when you do the investigations, the ultrasound of the abdomen reveals bright hepatic echoes, enlargement of the liver, and gallstones in the gallbladder. So which of the following is the most likely cause of her liver disease? Looking at the blood results, bilirubin is all right, alkaline phosphatase is mildly raised, AST is elevated, and ALT is elevated as well. So the albumin is 46, which is okay, and the ferritin is mildly raised. So what does this all point towards? So looking at the conditions, we've got gallstones, alcoholic liver disease, drug-induced hepatitis, non-alcoholic steatohepatitis, NASH as it's called, and hemochromatosis. The answer here is NASH, and the reason for that is, looking back at the presentation, it's a 33-year-old lady who's got all these symptoms which are a bit vague, and she's diabetic, which is a risk factor for NASH. She's on these medications. She has also got PCOD. Yeah, she drinks 15 units of alcohol, but that doesn't necessarily in excess, nor regulated being 14 units of alcohol per week. BMI is significantly raised. So all and looking at the blood results, the ALT is marginally raised. It's more of a hepatitic picture. So, and I mean, ferritin is mildly raised, but it's not in the ranges that you'd expect for hemochromatosis. And it all points towards non-alcoholic steatohepatitis, or NASH as they call it.